Good morning to everyone, and welcome to this 3D4Med and Matisse workshop on the MedFit. I'm pleased to welcome you. This presentation will be cut in 3 parts after an introduction. We will talk about periodontal problematics and 3D printing. Then we'll have an intervention from Pierre Guereschi and Romain Bosque on the how to legitimate, on how 3D printing in soft tissue regeneration could fit the clinical needs. And then we will close this session with a talk about 3D printing and regenerative medicine. So just to begin, I will give the mic to François and Samira. It's up to you. François, we can't hear you.
Yeah, can you hear me?
It's better. Yes, yes. Okay. Thanks.
So, yeah, can you see the presentation? So, yeah, I'm François Sirner. I'm European Project Manager at Lille University Hospital and especially Matisse Project Coordinator. So I will start by introducing first in the name of all the organizing team, the France Wallonie Flanders program, Interreg program, and then I will shortly introduce Matisse Project, and you will have the chance to hear the presentation from Professor Pierre Guereschi, who is the surgeon involved in this project afterwards. So first, I would like to tell you that you can use all these hashtags and tag Matisse_EU Twitter account to react to presentations. So polymers, 3D printing, bioresorbable, and regenerative medicine keywords. First, to shortly introduce the Interreg France Wallonia Flanders program that is supporting our 2 projects, 3D4Med and Matisse, I would like to give you some pictures and some information about this program. So first, you have to know that there are nearly 100 Interreg programs across Europe, and they are part of the European Territorial Cohesion Policy. And as such, their main goal is to erase barriers between countries and regions in Europe. And for example, as the name suggested, for Interreg France Wallonia Flanders, the area goes from northern France to Belgium, to Wallonia and Flanders, and especially Belgium, area of Belgium located next to France. So this program particularly decided to have 4 investment priorities. So the first one is to foster research and innovation. The second one is to boost SMEs' competitiveness. The third one is to promote sustainable development. And the last one is to promote social cohesion as well as culture. For that, the European Commission allocated a total amount of about 160 million euros to this program. And this budget is distributed among these 4 investment priorities, as you can see on the slide. And finally, if you wish to apply to such Interreg program, you need to know the answer to the question, what makes a good cross-border project? The first answer is that a good cross-border project should have a cross-border added value, then should be implemented at a cross-border level, and finally, should have an impact at cross-border level. So now it's done. I will go back to Matisse' presentation. So the first thing you need to know is that Matisse project is all about tissue engineering techniques for the breast reconstruction, but not only for breast reconstruction, more broadly to the reconstruction and regeneration of soft tissues. So to introduce Matisse, I would like to give you some key figures about breast cancer. So it's estimated by the World Health Organization that nearly one woman out of 8 women around the world will be affected by breast cancer in her life. And if we focus on Europe, France, and Belgium especially, you can see that in Western Europe, we have one of the highest incidence rate across the world, with on average 92.6 breast cancer per 100,000 inhabitants, female inhabitants. And this incidence rate in France is about 100, and in Belgium is about 105. And I have to say that Belgium has, unfortunately, the highest incidence rate of breast cancer in Europe. So what's the main surgical approach for breast cancer? It's the partial or total mastectomy, and it's estimated that it's about 35 to 40% of surgical interventions for the breast cancer. And only 25% of women who had undergone a mastectomy will benefit from a breast cancer. And this very limited number of breast reconstruction can be explained by several factors, for example, the fear, for example, the cost of surgical intervention, but also from the lack of alternatives to existing breast reconstruction techniques. So talking about breast reconstruction techniques, you can divide them into separate parts depending on the volume you have to reconstruct and also on the technique you want to use, so non-autologous or autologous techniques. So first, for the small volume, you can use lipofilling technique that consists in collecting blood and fat tissues, for example, in the thigh or in the lower abdomen, to centrifugate it and to re-inject the fat tissues within the breast to be reconstructed. When you want to reconstruct large volume, you can either use for first breast implants, such as breast implants using with silicone, but you all know that breast implants with silicones know a lot of issues in the last decade. And finally, you can also use the Dieppe technique that consists in collecting not blood and cells, but fatty or muscular flaps in the thigh, in the lower abdomen, or in the back, and to use it to reconstruct, to remodel the breast for the patient. But this last technique is very long, complex, and quite expensive, and also has the issue that it has a donor site morbidity. It leaves a scar to the patient and can sometimes be painful. So what are the main needs identified by us? So for the patients want to avoid silicone implants as much as possible. They don't want foreign bodies anymore. They want single surgical intervention and real-like breast reconstruction, as well as, if possible, a personalized reconstruction. For surgeons, they don't want complications, and they want an easy and reproducible technique for breast reconstruction that is also an affordable technique for patients. That is why in Massive Project, we developed a 3D printed matrix and scaffold to enable the tissue regeneration for the breast reconstruction. We developed a tissue engineering chamber that consists in a 3D printed matrix that is first rigid, closed, porous, and resorbable. This matrix encloses a flap that is fatty, local, and well vascularized, and it's about a third or a fourth of the flap that we can collect, for example, in the thigh or in the lower abdomen. And we put the flap under the tissue engineering chamber, and we put this under the skin. And then, as you can see at the bottom of the slide, the tissues will regenerate themselves and fill the empty space under the tissue engineering chamber. And at the end of the day, after 6 to 12 months, the tissues will occupy all the space and the tissue engineering chamber will progressively resorb itself. So it will disappear and it will only remain the newly generated tissues. Professor Pierre Guereski will further explain this afterwards. So you also have to know that for Massive Project, we now focus on interaction between biomaterials and human cells to better understand what are the factors involved in this process, but also to imagine new applications. And also Professor Pierre Guereski will tell you about possible new applications. So we are working with several partners on specification and protocols, implementation of biomaterials, of course, but also on 3D modeling, as well as on surgical validation. And our main goal is to achieve the TRL 5 or 4, and so to reach the preclinical trial stage. So our partnership is composed of 7 partners spread across France and Belgium. And those partners are specialized either on surgical aspects, cell aspects, on biomaterials and interactions between biomaterials and cells, and also on additive manufacturing, 3D printing, and also on in vitro resorption. And we also supported by Eura Materials and Eura Santé, that is organizing a MedFit event on the dissemination and communication of our scientific results. And it's all for me. Thank you for your attention.
So, Samira, it's up to you.
Yes, I'm here.
Thank you. Thank you.
Oh, I'm sorry. So good morning, everybody. It's a really great pleasure and an excellent opportunity for 3D4Med project to present with Matix project. Our progress about one-to-one shape memory polymer in plants for biomedical application. As Francois explained us, both projects are indirect projects with a cross-border cooperation program. The main objective of 3D4Med is to develop biocompatible shape memory matrices combining structure and activity biological surface using all opportunities of 3D printing and even beyond. Indeed, the general concept of our collaboration is to propose new polymers which can change shape, form after stimulus, such temperature, pH, or the mechanical action, for example. And in this project, shape memory polymers are mainly activated at 27 degrees to adjust the form to the defective tissue to be replaced. And for that, we can rely on 3D printing, which allows to develop objects responding to structural and mechanical properties required for cellular and tissue engineering with low inflammatory response, promoting self-healing. So 3D4Med is a collaboration made of academic research groups, university hospitals, and SME through transdisciplinary applied research in material science, tissue engineering, and medicine. So more specifically, the University of Mons in Wallonia proposed to coordinate the cross-border partnerships. This mission is efficiently realized with the collaboration with Eurasante, a French health cluster dedicated to tech transfer in life science sector. Another side, UMOS proposed also the expertise into additive manufacturing materials with functional properties. And today, UMOS works with these projects closely with the University of Ghent and KU Leuven to adapt these functional materials to biomedical application as artificial muscle. So the consortium can also rely on MIT Lille and Armin in France to prepare the scaffold of all new materials using 3D printing, and all material proposed are sent to University of Reims to investigate biocompatibility and biological activity. So before giving the floor to our speakers, I would like to thank our financial support, of course, and please feel free to send me an email or to visit our website for more explanation. Have a nice day for everybody.
Thank you, Samira. It was perfect. So now we can go on in this workshop, and I will give the micro to Johan Sergerhardt from University of France. So Johan, you can switch on your micro and share your screen. It's perfect. Thank you.
Yes, I hope that everybody can hear me on my screen.
Yes.
Sorry, let's start with the hand. So, Hello to everybody. I am Johan Sergerard, the doctor in dental surgery from Reims Hospital and a PhD student in Reims University BIOS Laboratory. I would like to thank Medfit to give me today the opportunity to explain to you how periodontal diseases and how tooth loss can be a new issue for bone regeneration. First of all, we have to define what is alveolar bone. The alveolar bone is a part of the entire human skeleton and more specifically of the craniofacial skeleton. It is a part of the maxillary and mandibular bone by continuing the alveolar, the basal bone. Sorry. This alveolar bone is constrained by all the homeostasis bone rules, as the fact that osteoclast can resorb the old or injury bones, introduce the presence of osteoblast cells, able to synthesize osteoid matrix and to mineralize it. The particularity of this alveolar bone is the presence of the tooth linked to the alveolar thanks to periodontal ligament. This particularity is very interesting because if we lose the tooth, we have a contraction of this bone. In fact, through tooth extraction, because of caries, infections, or other problems, we observe a contraction in vertical and horizontal dimension, as you can see on this picture. On the left picture, we can appreciate in pink the periodontal ligament linking tooth and bone. Another causes of bone loss are periodontal diseases. In a periodontal healthy patient, we can observe that there is an homeostasis between the host response and the microbiota. The tooth is surrounding bone and soft tissue. In the presence of gingivitis, that is a local reversible inflammation, we observe the start of an inflammation only limited on soft tissue. Without treatments, this biofilm go deeper, change its composition because of the changement in physicochemical status of the periodontal pockets, and increase inflammation, recruiting osteoclast and causing a bone loss. Sorry. So all this oral bone loss theory correspond to specific clinical problems. On this first photograph, you can see that there is an apically displacement of the soft tissue to the teeth, and let's appear cementum tissue. This recession can cause aesthetic injury, but also pain. The cause of this migration is the lack of bone, as you can see on these X-ray radiographs. In fact, there is inflammation caused by orthodontics injuries and firstly because of the bacteria that cause the bone loss. One of the objectives of periodontal surgery are to perform a bone regeneration. As you can see on the right photograph and X-ray, thanks to periodontal probe, we can appreciate the infrabony defects, and through a flap, we can highlight this defect and put some biomaterials as enamel matrix derivative from Straumann and Degen, for example, or biomaterial graft to perform bone regeneration with some good results in this case, for example. Another clinical problem is when we lose the tooth, we only keep the basal bone. Sorry. On this CT tomograph cuts, we can observe the maxilla and the mandibular bone. One of the possibilities to replace this organ is to place an implant in bone. However, in these two sites, we have some noble elements as the sinus cavity and the mandibular nerves. These two noble elements have to be respected and can limit the implant surgery. Another limitation is the fact that implants have to be placed with enough bone thickness to assure the stability and all the constraints in the mouth. So, for example, pre-implant surgery can be performed to make easier implant surgery. Sinus lift is one of the most important, and shortly, the sinus lift consists in the elevation of a flap to highlight the sinus bone, to perform a bone window to highlight the sinus membrane. The sinus membrane is pushed up, and thanks to a biomaterials, we can keep an healing space, and membrane is placed to perform a good healing cicatrization. All the regeneration is performed thanks to biological principles, and the first one is the histocompatibility of all surfaces. In fact, we need to have clean surfaces to perform bone regeneration and increase cell proliferation. One of the objectives of biomaterials are their antimicrobial capacities, because mouth is full of bacteria surrounding all tooth and can cause periodontal diseases, as we have already seen it. The second principle is the tissue exclusion. In fact, surrounding the tooth and in the mouth, there is 4 principal different cell types in presence: epithelial cells, fibroblasts, osteoblasts, and desmoidal cells. All these cell types present some different healing rate and proliferation rate. For example, the 2 first one, epithelial cells and fibroblasts, have a proliferation rate around 0.5 millimeters per day, and the 2 last one, osteoblast and desmoidal cells, 10 times less proliferation rate, around 0.05 millimeters per day. This difference cause different healing consequences. For example, if there is a majoration of epithelial cell proliferation, we observe a long epithelial junction. If there is osteofibroblast, it's roots resorption. In presence of osteoblast high proliferation, we observe an ankylosis. And what it is interesting is to increase desmoidal cells proliferation that can keep us in regeneration healing. Third principle is to maintain healing space. As you can see on the left picture, if we perform tooth scaling or a surgery without any biomaterials, there is put down of the soft tissue of the gingiva, because the blood clot is not mechanically sufficient to keep the healing space. So in periodontal surgery, we had a membrane that protects the blood clot and keep the gingiva at this place. Another properties of the membrane is the capacity to perform an desmoidal cell proliferation higher. Without tooth, it's the same problem. Blood clot is not enough to perform a good healing space, so dent effects are performed through the membrane, and in some cases it's not sufficient, so we have to add a bone substitute to perform a support effect added with a membrane. Clot stability and clot adhesion are performed through the sutures, and the cell induction is able thanks to autologous bone grafts, for example, from maxillary and mandibulary bone or from calvaria human bone himself. Another possibility is the use of autologous concentrate platelets as PRP or PRF. Thanks to blood collection and centrifugation, we have the possibility to use these products. And the last one are enamel matrix derivative, as Mdegain presented previously, that all present good results in periodontal and bone surgery. However, the principal limitation of the use of autologous bone graft is the presence of a second surgery site, the increasing post-operative infection, and the limited quantity of bone that can be used. For biomaterials, there is also an infection risk, the lack of biomimetism, and the costs that stay higher in our specialty. Also, in sinus lift, there is some major problem as the perforation of the sinusal membrane, the loss of bone substitute, and post-operative infections. All these limitations can increase the tooth loss and the infective sites. So 3D printing can be interesting in our topics, tooth loss and periodontal diseases, because if we know, thanks to a city, that we want to put the implant in that position, for example, 3D printing could be interesting to perform an modelized biomaterials to increase the chance to put the implants. And the same thing can be imagined surrounding the tooth, because, for example, for now, we use only bone granules that not always adapt to the clinical problems. Thank you for your attention, and let me know if you have some questions.
Thanks a lot, Jan. Maybe we can move on with the presentation of Marie and ask a question at the end of their presentation, because it will be in regard of the problematics you present. So yes, Marie, start to share screen. It's perfect. Now it's up to you. We can't hear you.
Okay.
Yeah, it's better. Thanks.
Thank you. So, good morning, everyone. I'm Marie Dubus, a postdoctorate student from BIOS laboratory in the University of Reims in France. And I'm glad to share this presentation with Marie Bayard, who is also a postdoctorate student, but she's working in IMT Lille-Douai in France too. We are working in collaboration thanks to the 3D4Med project, which was previously presented. And one part of this project is the development of scaffolds for bone regeneration. And in this context, we are developing 3D printed scaffolds in IMT Lille-Douai. And in the BIOS laboratory in Reims, we have all the expertise to test these scaffolds for bone tissue engineering applications. So to introduce to you our project, you need to know that tissue engineering is an important field of regenerative medicine that aims at combining regenerative cells with scaffolds on which they can adhere and proliferate. They can develop on these scaffolds with the help or not of biological factors. And the goal of tissue regeneration, of tissue engineering, is to repair or regenerate all the organs of the organism. In our case, we are interested in the development of scaffolds for bone regeneration. And you need to know that the best scaffold for tissue regeneration is the scaffold that mimics the best the tissue to regenerate. So in our case, we need to know that bone is a hybrid material composed of calcium phosphates, but also is composed of a non-organic part and mainly collagen fibers. To be used in bone tissue engineering, the scaffold is implanted at the damaged site to replace the missing bone, as long as necessary for the bone to regenerate. And then the scaffold is degraded while the bone is regenerating. That is why the scaffold needs to lure the original bone by mimicking it the best possible way. And in order to develop the best bone scaffold, we therefore have to respect strict features for the scaffolds. And the first feature we have to respect is the scaffold composition. Indeed, the scaffold needs to be tolerated by the organism, of course, so it needs to be biocompatible. But the scaffold also needs to be bioactive to stimulate the bone regeneration. And then, as we mentioned previously, it has to be biodegradable and hybrid to mimic the bone. Then, regarding its geometry, the scaffold needs to fit where it will be implanted. So the shape must be adaptable or controllable. And also a crucial parameter of the scaffold, its porosity, because the porosity allows the invasion of cells inside the scaffolds. And we have to choose the good pore size in order to have the right cells inside the scaffold. And moreover, the cells inside the scaffold need to be fed. So the pores need to be interconnected in order to allow the exchanges of fluids and nutrients to the cells. Then the topography is also important because, for example, the roughness can stimulate the stem cells. So the stem cells are the cells in the organism with no function yet. And when they are stimulated, they can become specialized cells. And in our case, we would like to influence the stem cells to become the bone-forming cells. That means the osteoblasts. And we also know that the mechanical properties are a crucial parameter because it influences also the stem cells' fate. And as I said previously, we would like to have a scaffold with the same mechanical properties as the bone. So we have a lot of properties to respect in order to achieve the perfect scaffold for bone regeneration. And Marie is going to show you that 3D printing seems to be an ideal method to achieve our goal.
Hi everyone, in this part of the presentation I'm going to introduce to you the 3D printing technique we are using at IMT. So it's an extrusion-based additive manufacturing technique, meaning that the polymer is melted and extruded through a nozzle, and it permits to build an object layer by layer. So in the little video you can see here, this is our machine, the freeformer from Harburg. And you see that it enables to use pellets instead of spools that you sometimes see in the different other 3D printing techniques. So you see the pellets are fed in the screw, and then it has an injection unit. And just after that, a post-nozzle closure that enables the deposition of droplets and not filaments as in the other techniques. So the droplets are deposited here on the first layer. And when this layer is over, the building platform will move down and the second layer will start to be deposited, and then until the end of the part, until the last layer, the platform will move down and finish the work. So in the next slide, you can see that it has a high precision for the production of scaffold. Here you can see the droplets being deposited on our scaffold, and it also enables to print several scaffolds at the same time. So here we print 5 scaffolds at the same time. In the next slide, you can see that this technique has many advantages and drawbacks. Advantages because it permits to build personalized implants of complex architecture, because we can very well control the structure and the porosity, as we can adjust many parameters. I will talk about it later. And it's very fast, and it's an easy to handle technique. But also it has some drawbacks. We can use mainly thermoplastic polymers, so it reduces the possibilities. It has a limited general porosity because we deposit thick filaments of droplets, as compared to techniques such as electrospinning that can reach like 90% of porosity. Here we can reach a little bit less. And there is a lack of available raw materials for biomedical applications, so we need to develop new ones. And also there are phenomena of thermal distortion like warpage and shrinkage, like as you can see on the picture. But here in our case, it's very limited because we are using amorphous polymers. So in the next slide, so we have requirements, as Marie told you before. So we need biocompatibility, bioactivity, and biodegradability. This feature, we can reach them by using polylactic acid and hydroxyapatite particles that have these features. But for the structure and architectures, we need 3D printing to reach the required features of porosity, interconnected pores, filament thickness. We need the thin filaments, and the size of the porosity also need to be quite small. We need to reach here 350 micrometer. We found these features in literature review. So in the next slide, to reach porosity with 3D printing, first we can design a solid cylinder through computer-aided design, and then we can vary the porosity by finding an adapted infill. So in the slicer software of the 3D printer, you can choose to fill more or less the cylinder, so you will have different porosities. Then for the filament thickness, you can adapt different nozzle diameters. So for example, for the freeformer, we have 3 different nozzle diameters. So you may think we will choose the smallest one, but we have to keep in mind that we are using particles. So we we don't want to clog the nozzle. So maybe we needed to choose a little higher diameter one. So we chose 200 micrometers. And also we have to keep in mind to choose the good slicing distance. So that's in also the slicer software of the machine to choose the layer thickness. So depending on the nozzle we chose, we will choose a different layer thickness. Also for the pore and shape size, we can choose different deposition orientation also in the slicer. So here you've got 2 examples. You've got 0, 60, and 120 degrees, and 0 and 90. So you see that these different deposition orientation will give different pore shapes, so triangular or square, and also different sizes. So this is to keep in mind when we design scaffold. And there are many other parameters such as temperature, the Z offset, but I will talk about it just later. So in the next slide, you can see we did qualification. We tried different parameters and we had many failures. So here you can see that in the first picture, we have a too high infill percentage. So we have a low general porosity. We've got very small pores. So this is not good for the cells to exchange fluids and nutrients. In the other one, we've got a too low infill percentage, we've got very big pores, and also we chose the wrong slicing distance. So we had a big collapsing of the structure and also free deposition. So the structure is not good at all. In the next slide, we chose the wrong temperature. We are using PLA, which is subject to hydrolysis. And here we chose a too high temperature, and the polymer got more and more fluid because it degraded. And this shows a lot of hydrolysis. So we had to choose a lower temperature. Here we see that we have first layer flattening, that because we didn't choose right the Z offset. So the Z offset is where the 3D printer starts printing. If we choose a low Z offset, the nozzle will start printing very close from the build plate and it will flatten the first layer. And if we choose a too high Z offset, we will begin to print very far away from the building plate, and we will have low adhesion to the build plate. So we tried different Z offsets to avoid flattening, because flattening means that there is no porosity on the first layer, and it hinders exchanges of fluids and nutrients. And then we had a very nice porosity with the good Z offsets, and so nice exchanges. Also, the first time we printed with contours, and we noticed that there were no fluid exchanges, so we needed to remove the contours, and it enabled better fluid exchanges in the end. After many trials that we call here a qualification, we obtained optimum parameters, and the scaffold had very satisfying features. Here you can see that we have nice open porosities, interconnection. The pore shape is fine too. The rods are straight. So we were very satisfied with this result. And we made SEM observation, scanning electron microscopy observation. Here you can see that the first layer is not too flattened. It's a bit flattened, but we can see that we have porosity. The last layer is also satisfying. We've got straight rods. The porosity are of good size. And also inside the scaffold, it's also porous. So we think that the exchanges will be good. And now Marie will talk about the biological result on this scaffold that she obtained. Thank you very much.
Yeah, so the next step was then to check the biocompatibility of these scaffolds. So for that, we seeded some cells on the different scaffolds during 21 days. And I wanted to show you on this graph the differences between the scaffolds we chose at the end with no contours and the scaffolds with the contours. Because you can see on this graph the cell viability at day 7 and day 21. And we observed that at day 7, we did not see any differences between the cell viability inside the two scaffolds. However, at day 21, we observed that the cell viability was far more important for the scaffolds with no contours, which means we have a lot more living cells inside these scaffolds. And that means that we have more and more cells over time inside the scaffold with no contour. So they are pleasant for the cells and biocompatible. However, we don't see the same cell proliferation over time for the scaffolds with the contours. And as Marie mentioned previously, we think it's because of the lack of exchanges of fluids and enrichment to the cells. After the 21 days of cell culture inside the scaffolds, we observed the cells inside the scaffold. So it was only for the scaffolds with no contours. And you can see on this picture the nuclei of the cells in blue. And in green, this is the cytoskeleton of the cells. And we can see that we have a lot of adhered and aligned cells along the fibers of the scaffolds, which confirms that this scaffold is well biocompatible. So to conclude, 3D printed technique allowed us to obtain scaffolds with most of the required features we would like for bone regeneration, because it allowed us to support living cells inside the scaffolds because they were biocompatible and they had the good porosity. And in perspectives, we need to continue to investigate the scaffold properties, especially the degradability of the scaffolds and the mechanical properties. And regarding the biological properties, we would like to observe the stem cell fate, if the stem cell fate is influenced by the scaffold to become osteoblasts, for example. And to conclude on this collaborative project, I would like to say that it's important to notice that the collaborations between labs with their own expertise are crucial to achieve such pluridisciplinary projects, because this project started from the development, the characterization, and to the biological studies and applications. And thank you for your attention, and we are open for the questions.
Yeah, thank you, Marie and Johan, for this really interesting first part. Maybe some of the other person present right here have some little question on your presentation. We have time. We have 3 minutes, so I don't know, François, Samira, or Pierre. No. It was really clear. People are a little quiet in the chat. What I propose is that everyone stay tuned. We will have a short transition and we will move on the second part of this workshop. and welcome back on this 3D4Med Matisse workshop. So we are now moving on the second part, and we'll talk of 3D printing in soft tissue regeneration, return of experience on the clinical side. I'm pleased to welcome Dr. Romain Bosque and Dr. Pierre Guéreski for this second part. And I give the microphone to Romain Bosque to start. So Romain, it's up to you. You can share your screen. And it's perfect for me.
So good morning, everybody. I hope that everybody can see my screen, but I think that it's okay. So we will begin with the planifications and the 3D printing, an in-house technique from 3D printing to augmented reality, the experience of my unit in Henri Mondor Hospital. So I'm plastic surgeon. I work a lot on 3D reconstruction for head and neck cancer. And of course, the major problem of this pathology is to reconstruct soft tissues and bones after large resection. And since 30 years, we are used to we use the CD printing, the planification, the computer planification to help the surgeon for the reconstruction. But it's not new. Since 1,000 years, plastic surgeons from the antiquity use schema and schematic planification to reconstruct the soft tissues of the face. But now, since 30 years, we use computer planification, of course. And there is a lot publications on this subject because it helps plastic surgeon and head and neck surgeon and maxillofacial surgeon to reconstruct patients after head and neck cancer. The problem is that most of this planification, these CAD/CAM, are done by external companies. And of course, for surgeons and for health center, it costs money to buy these planifications and these cutting guides. Even if it's help a lot our patients, we need to ask those external laboratories for the planifications and for the made of the cutting guides. And sometimes the result is perfect, but sometimes the planifications needs time, sometimes 4 weeks, 5 weeks, and if the time is too long, the cancer increase and spread, and sometimes the cutting guides or the planification don't correspond exactly to your project of reconstruction. Since 8 years, we have tried to internalize the process of 3D planification and 3D printing to have our own handmade cutting guides. So the first time was to learn to use the reconstruction with the slides of the tomographic slides. Then we have learned the CAD/CAM, and then we have learned the 3D printing, after all, the sterilization and the use of the cutting guides. So the first step was to use the volume rendering softwares from the scanner of the patient. So we are used to, for us, it's easy to use because we do it every day in our health centers. The second step was to use the conception-assisted design softwares. So there is a lot of softwares and freewares, but the problem is to choose the right one and to learn to use it. And it's not easy. It needs time. It needs teaching. And we have spent at least 1 year to teach to our different doctors in the unit to use different softwares for the conception-assisted design. But it's with these softwares that we are able to make our own cutting guides from the 3D reconstruction of our patients. So there is different CAD softwares. Sometimes they are free. Sometimes they cost a lot. It depends on the different options of these softwares. But when you have done your 3D reconstruction, it's not finished. You have to print your object to have it really at the surgical room. So the second step was to choose 3D printers. So there is a vast amount of 3D printers, and we have done different choices. And at the end, we have chosen two 3D printers for the print of our cutting guides. So the choice was difficult, and we have chosen at the end the acrylonitrile butadiene styrene because it's really easy to use, and we will see next for the sterilization. So at the beginning, it was very hard to do it. I need at least 14 days to make my own cutting guides, and it was a really premier cutting guides. And with time, I'm able to do really perfection, really acute cutting guides, specifically designed for my surgery, for one patient, with all the refinement necessary for my patient. But once you are cutting guides, it's not finished. You have to sterilize it and to do a process of agreement to use it at the surgical room. So it was a very long process. We need at least 3 years to circle all the problem for the sterilization. So what kind of machine, one kind of sterilization, how to manage the risk of bacteria, of virus, the quality of the cutting guide before and after the surgery. So all of this has been published in many journals. And at the end, we are able to do our planification, do our own cutting guides, sterilize our guides, and of course, use it at the surgical room. So is it feasible? Yes, is it feasible? It needs time. You have to teach, you have to manage, you have to control all the formation of your team. But of course, it's possible. It's the same process that you have in external laboratories or in companies. And of course, this process makes you able to improve the quality and enlarge the capacity of your team to use your 3D printers for others surgery, for others projects. Is it affordable? Yes, is it? It's the same problem. When you are able to do your own conception-assisted design for your cutting guide, you can you can do your guides with perfection and to design it exactly for your project of surgery with different design, with different shape. And when you use it at the surgical room, you are not surprised by any problem because you have done it sometimes the day before or 2 days before. So you see that for now, for less than 200 euros, you are able to have your own cutting guides in your surgical room. So what are the real advantages? The planification, the flexibility, and the training and education of your team, because you design your guides in your units. You are not needed to give information and data to an external company. During the surgery, of course, you are able to go fast. Why? Because you have done already your surgery on your computer before the surgery. And you are sure that the quality of your guide is exactly designed by your needs. And during the surgery, you can improve the quality of the shape of the plate, for example, on your guides, on your models. So here you have the examples of the use of the guides directly on the surgical room. And most of the time, of course, the guides and the models correspond exactly to your surgery. Remember, you have to remember that sometimes we do the guides and we print it just the day before or 2 days before the surgery. So you have not the risk of losing time of waiting that the guides comes from United States or China. And you can improve, it's just your imagination. You can do guides for implants, you can do guides for the mandible, for the maxilla, for the fibula, for the skull, for what you want. So I have 2 questions for you. Less than 200 euros, less than 48 hours to get your guides. Is that not too expensive and too long? Look closely at these figures and this animation. What do you see? You see that when you have your guides on your computer in 3D, you can imagine that you can maybe use it directly at the surgical room without 3D printing, but maybe just in your eyes. So what's that? It's augmented reality. You don't print your guides and you put it directly in stereoscopic glasses and you try to do the surgery with the guides directly in your eyes. So of course, now you know me and I have tried it at the surgical room. So we have about stereoscopic smart glasses, and instead of printing my guides, I have put it directly on my glasses. And of course, I have tried for my fibular and maxillofacial reconstruction. And of course, it was not easy because we have a lot of problem with the visualization of complex 3D objects on devices that are not specifically designed for this use. So for me, there is a lot of applications of this new technology. And you know that it's not usable only for the surgeon. It's usable for all your team and specifically for training the residents. You have to understand that there is a large difference between augmented reality and virtual reality. The augmented reality is just the add of 3D objects in your real environment. It's not the use of a virtual environment. So it's very hard to add these objects in your real environment when you are in the surgical room, because the lights are very specifically. You have to have a good sight of your operating field. So there is a large and a hard development to do to have this technology very usable and ergonomic. So here you have an example of the use of augmented reality with 3D objects directly on the surgical room, for example, for breast reconstruction with a DIEP flap. The DIEP flap is a tissular harvest of the abdominal wall based on the perforating vessels. And the try of this try was to see these perforating vessels directly on my stereoscopic glasses. Thank you.
Thank you a lot, Romain, for this really clear presentation. I propose we move on the presentation of Pierre, and then we'll have a few questions for both of you. So Pierre, you can switch on your microphone and share your screen.
Yes, thank you.
It's good for me. So it's up to you.
Okay, good morning, everybody. Thank you, Romain, for your talk. And let's have a look to the soft tissue reconstruction. So I'm Professor Pierre Guéreschi from Lille, and I thank you for giving me the floor about 3D printing. And soft reconstruction. So next. Okay. So in the field of surgery, especially in reconstructive surgery, 3D printing gives us a great opportunity. It is personalization. Each unique patient, each unique clinical case can be solved by a tailored therapy. And if a tailored device is needed, then the patient could have it and the surgeon could build it. 3D printing is a new tool to make a unique device for a unique patient. So bone surgery, as shown by Dr. Bosk, has greatly developed personalized tools like cutting guides and curve planings. But how about soft tissue reconstruction? Although soft tissue reconstruction meets the same needs in terms of customization, the constraints are not the same. In soft tissue reconstruction, we expect biomaterials to be deformable, to be flexible, soft. They have to be able to move naturally, to be tolerated by surrounding tissues and well accepted by the patient. Currently, different approaches are being explored to improve soft tissue reconstruction, like regenerative matrix or dermal matrix, for example. 3D printing is often a technical means available to these innovations because 3D printing allows prototyping and tailor-made. But here I would like to give you a personal example of the use of 3D printing in soft reconstruction, that of a tissue engineering chamber printed in absorbable biomaterials. The proof of concept was illustrated by an animal model here performed in rats. We were able to embed a vascularized fat flap in a tissue engineering chamber placed subcutaneously. MRIs performed regularly allowed us to measure the growth of the vascularized fat flap in the tissue engineering chamber. And while the rat's weight remained stable, we were able to measure a doubling of the fat flap volume in the tissue engineering chamber in 3 months. This approach, which promotes the growth of fat, can be used favorably in breast reconstruction to reconstruct breast volume. Our innovative solution is called Matisse. It is a tissue engineering chamber printed in absorbable biomaterials, and we want this solution to be simple, because there's no need for microsurgical flaps. We want it to be single, no need for removing the device, and as safe as possible, obviously. Our innovation led to a patent in 2016, and research and development is currently carried by Lattice Medical, a 3-year-old startup. The production in a clean room of tissue engineering chamber of a size adapted to each patient will allow us by 2022 to have a first-in-woman implantation. The surgical plan for immediate breast reconstruction after skin-sparing mastectomy with our Matisse device is based on 4 stages. First, raising a flap, a fat flap. The donor site should be as small as possible, reached by the same surgical approach through the inframammary fold, for example. Secondly, embedding the flap in the tissue engineering chamber. You can notice that the base and the dome of the chamber are removable, and they can be easily fixed between them. After that, in a third step, the chamber Matisse has to be secured in a pre-pectoral pouch. And after all, last step, the inframammary fold can be closed by the abdominal skin advancements. So thanks to an anatomical study performed by our team, several fat flaps can be raised. They are, for the most, vascularized by perforator vessels from the thoracic area. One of the most useful flap could be the lateral thoracic artery flap or the lateral intercostal artery perforator flap, LICAP flap. So these 10 past years of research in the field of soft tissue engineering at the Lille University Hospital have seen the filing of a patent, the emergence of a startup, and the rise of a whole research team supported by regional funding and then by European Interreg funding. Our next milestones are the optimization of the production processes of chamber printing of absorbable biomaterials with a view to a first-in-women implantation in 2022. Our current research is more particularly focused on the interaction between biomaterials and soft tissues to develop other clinical applications. In plastic reconstructive surgery, so this surgical specialty has a wide range of patients and pathologies to treat. In some of them, 3D printed skills are needed. So for first example, I will give you 5 examples. For the first one, it deals with burnt patients. You see here that deep burns cause irreparable loss of hypodermis, and a surgeon can heal these terrific wounds with skin graft, but the sequelae are important in terms of softness, thickness, and elasticity, for example. Second example, in the field of craniofacial malformation. I'm a craniofacial surgeon and I have to repair with my team about 100 of newborns per year with cleft lip and palate. In this pathology, some patient needs bony repair of the maxilla. And this is a tricky operation because the surgeon has to model a tiny piece of bone to fill the space between the two edges of the maxillar cleft. This is another project developed thanks to 3D printing in our team. We were able to build a simulator or a task trainer to train our interns to suture the soft palate in a 10 months old children mouse. One of the interests of 3D printing in this project was to be able to offer interns different sizes of mouse for a gradual training. Next, sorry. Sorry for the slide, but my last example was about my favorite subject, the rehabilitation of facial palsy. And this pathology is very socially disabling, and it can be treated by nerve transplants and muscle transplants. And we need efficient biomaterials to spare donor in these conditions. So finally, as Dr. Bosk said, it is essential to teach 3D printing in medicine. And so 3D printing has to be taught as a discipline in its own right at the Faculty of Medicine. And I made proposal in this direction recently, and I would like to be able to propose soon the opening of a university degree for 3D printing in Lille. So I thank you for your support, and thank you all for your attention.
Thank you a lot, Pierre and Romain, for your two great presentation. I know that maybe Samira have a little question. So Samira, please, you can switch on your microphone.
Just a problem with mouse, sorry. So yes, I have two questions for women and one for Pierre. So for women, first, if I understand your presentation, maybe I don't know if I understand everything, but so for you, the future for the hospital will be to include an additive manufacturing department or 3D printing department into hospital?
Yes, it's already done. When I began, I thought that I was the only one, and I was very proud of me. Yes, I have my 3D printers in my surgical room. I'm the best. But when I turn back, I have seen that in my hospital, there is two other departments with 3D printers. And the first one, and we don't think about it, it's the odontologist. They have three, in my hospital, they have 3 3D printers. They have one for the reconstruction of the crown of the tooth. And they have even one extruders. It's a very big 3D printers for the reconstruction of the prosthesis for the tooth. But it's not finished. In the department of cardiologic surgery, they have one 3D printers very specific for the reconstruction of some valves for the heart. and it's not they don't use it directly on the patient, but they use it to conform before implantation porcine valves. So it's already done in numerous hospitals or health centers. There is already 3D printers, but it's not. It's difficult to understand that most of those 3D printers are sometimes not used directly on patients. They are used for different applications.
Thank you.
But it's
did you have not some inflammatory with ABS polymers or no?
Alors, you have understand that the use of my cutting guides are just done during the surgery. So you use it on the bone, and when you have cut your bone, you remove it. You don't let it on the patient, of course.
Okay.
Now, at the moment, there is no applications for me of 3D printing except for some specific material like polyethyl ether ketone, for example, for the skull. Okay? But except silicones, polyethyl ether ketone, methyl methacrylate, or polylactic acid, there is no material that you can let in your patient. And of course, metallic material like titanium or silver or gold. Okay?
Thank you. Thank you very much.
The number of material that you can let in our patients is not vast. You have only specific materials.
So thank you very much for your clear presentation. It was really, really interesting. And for Pierre, I have also one question just about the size of scaffold for breast. So if I understand your presentation, nowadays you have to do a large open to place the implant breast, no? So I don't know if it will be more interesting for you if you just to do a teeny open to put your implant breast, and after you can have the good shape of the breast. If you have a good, of course, if you have a good materials for that.
Thank you, Samira, for your question. It's really important for plastic surgeon to have the smallest scar as possible, of course. But in a first step, in breast reconstruction, we are not afraid about scars. Because the first need is the shape and the volume, and if you have a good shape and a long scar, it's not so bad. So of course, if the biomaterials would be more deformable or more elastic, we could reduce the scar, but for the moment we need about 10 centimeter scar approach in the inframammary fold to put our chamber in the right place. So it's not a too big scar, but it could be minimized if we would have a more elastic biomaterials.
Thank you very much for your answer.
Perfect. I think François have a little remark and a question.
Yes, I wanted first to thank you for your question and interventions. I wanted first to emphasize that we are also working on other designs for the tissue engineering chambers, for example, to reduce as much as possible the scars to place the matrix under the skin. So yeah, to reduce the possible scar. And I'm very interested to understand that we have some similar constraints and similar needs between soft tissue reconstruction and bone tissue reconstruction. For example, with constraint of infiltrations and the fact that your matrix doesn't have to have contours, as Marie mentioned earlier on. So that's the first remark. And then I would have a question for Pierre and Romain. What are for you the main identified needs for a training of surgeons, and how many surgeons would you like to train, let's say in the 5 coming years? What are the main needs you have identified for such training programs?
For me, it's all the surgeons. So if you see only the French surgeons, I think that all the surgeons, and especially the surgeons who works on bone supports like maxillofacial, like orthopedics, like neurosurgeons, are interested now by the 3D approach. It's not really the 3D printing. It's all the 3D approaches, conception assisted design, volume rendering, surface rendering, 3D printing, augmented reality, and sometimes virtual reality. Now it's already on the formation and on the teaching, and most of the university, the faculty, push on the teachers to use these new tools. There is a limit, of course. There is a limit between the use of this new technology for teaching and the real technique approach. That's why, for me, there is always a need of cadaveric dissections, and after all, the first teach on patients. But there is a very, very hard push of the university to enlarge and to spread the teach on 3D tools.
Yes, thank you, Romain. I wanted to add something about education. You're completely right. All the surgeons need to have these tools in their hands, and not only the bone surgeon. But I wanted to add that 3D printing should be taught for every medical student, because in other fields they can use it, and for example, for rehabilitation doctor, they probably can use it, and so in our medicine faculties, we need to teach 3D printing, volume rendering, and plannings, and all these things, and also regulatory and specificity.
And I can add that it's not only for medicines, for doctors. Now there is a lot of nurses who use the 3D visualization and the 3D tools to simulate some acts like blood sample harvesting, like clinical examinations. So I think it's the use of 3D tools is the future, and it can be included in a large modules of teaching, modes of teaching. It's not only, it's not for surgeons, it's not only for doctors, and even it's not only for doctors.
Thanks for your very comprehensive answer. Thank you.
Thank you, both of you, for the presentation and the very complete answers to the question. For the audience, just stay tuned. We'll have a little transition, and we'll move on to the third part of this workshop.
See you. Bye.
Bye. Bye. Thank you.
Welcome back on this third and last part of the 3D4Med and Matisse workshop. We have been joined by Jérémy Audin from University of Mons and Maxime Legrand from CIRIS. And we'll move on the last part, which talk about 3D printing and regenerative medicine, which technical approach could fit the needs. And to begin, maybe we can give the microphone to Maxime. It's okay for you?
Yes, it's okay for me. Okay.
You can share your screen.
And I will share it. Okay. Oh. Sorry, it's this. Can you see everything? Yeah. Okay.
Yeah,
can you see it?
It's perfect.
Perfect. Okay. So which technical approach could fit the needs for 3D printing and regenerative medicines? As you may know, there are a lot of processes in additive manufacturing. If you can see this image, there are quite a lot of them, quite a lot of different ideas, and it's not full. There are even more than them, and there are new ones that are arriving every day. So what are the ones that are made for medical applications? So you will see some with photopolymerization. So it's a use of UV reactive resins and a UV light, which is either a laser or a projector. You will see also extrusion-based techniques like FDM, where you use thermoplastics. Material jetting also. It's small droplets like a printer, like a 2D printers, and then the droplets are cured again by UV light. And you will see the powder bed fusion techniques. So to print metal parts or plastic parts, it's the use of a laser that just melts the material. So it's a lot of techniques, and maybe you don't know where to start with. There are also techniques like ceramics, which use techniques like DLP, SLA, FDM that we just talked about here. So one of the main thing is to ask what are the materials you want to print. At first, it started with only a few of them, but now you can see there are quite a wide range. Goes from polymers to metals and ceramics, and now also biomaterials. So in polymers, you have, for example, PEEK, PCL, PLA, which are bioresorbable. With PCL, which is bioresorbable. So you have also titanium, which is a classic one. in medical 3D printing, and also ceramics, where you have hydroxyapatite and TCP, for example, which enters in the bone compositions, and then you have now biomaterials that are arriving on the market. The first example I will go through, it's not yeah, it's a network project where we work on printing an aortic valve, and the way is to print directly the polymer. So here it's the use of a polymer. It's not aimed to disappear, so it's to stay, but maybe later in a later stage, this polymer could be replaced by the building blocks of a real aortic valve. So here it's the use of a direct printing. As you can see here, I will show the video afterwards, and it can be directly or indirectly. So you can see here the valve is being tested, and here it's a printing using a syringe extruder with UV light. So you can see the purple light, which is UV light. So the big advantage here is the patient-specific one. The second example I will go through is the hip implant in titanium. Why is it important? Because you can see here that it has a lattice structure, and lattice structure is good for cell colonization. Then you have a good osseointegration. The lattice structure leaves space for cells to colonize the implant, and you have a good adhesion of the implant within the body. And also we can make it patient-specific, adapted to the design. Again, that's one of the big advantages of additive manufacturing in medicine. Usually it's for that also. So now if we go to a third example, which is a little bit different. So it's the Matisse project. We talked about it, so I guess you heard about it earlier. So it's a bioresorbable implant. Here, why use AM in this case? You have bioresorption after a known time. The use of additive manufacturing is even more important, because then you can say, yeah, here I want more thickness because I want it to last longer. With the shape, you can really have an impact on how long it will take to resorb. You don't have any residues afterwards because you use materials that will disappear after time. Patient specific also, here you can see really for this application, you can see here that it's really important for the woman to have something that fits what she needs with a rigid copolymer. So you need it to be rigid in order to keep the shape. And another advantage of AM is that you can have something complex in terms of shape for an easier surgery or better for other needs. The bioceramics is also quite important here. So we talked about it earlier. I told you a little bit about. So you have hydroxyapatite and TCP, which is the bone chemical composition. So it's quite important. Then you have no problems of biocompatibility, and TCP is bioresorbable. So that's also a big advantage, is that afterwards you will have no trace of the implant that you had it if you use TCP. So these 3D structures, they are ideal for bone integration, and again, you can use lattice structures to have a better osseointegration, and then you can make them custom made. So if I go back to the microporosity, we made some studies here. So the pictures in the bottom right, where you can see there are different holes in terms of shape and size, and it was to try in which types of holes does the cell like the most to go, which gives the better results. And then afterwards you get to this kind of shape, which is the best, for example, for cell colonization. For that, in bioceramics, we worked, for example, with Casius, which use this kind of techniques to print implant for the bone to stick to vertebra together. So they print a lot of different parts, 20 types of parts for different sizes, which give 150 parts with 3D lattice structures for bone regeneration, and not a lot of parts, 10,000 parts per year. So AM here is the best. Why? Because you have small parts that are complex in terms of shape. You don't have a lot of each different parts, and the production is flexible. You can really adjust to what you need, and you don't have any. You don't need any storage, physical storage. You can just print them on demand. So Cirrus, what did we do? We developed the process, the paste formulation with gaseous powder, and the parameters optimization, and then we produce for them for 4 years until we help them to integrate this into their own factories. The fourth example is Serum. So what's interesting here, so it's a startup created in 2015 by Gregory Nolens, which worked on the development made by Cirrus on AM and bioceramics. You can see here on the image the bioresorption. So here, the implant here, you can see here, the hole, it's holed with the screw, etc. But afterwards, it's completely healed. You have the bone just colonized the implant, and then it's just disappearing. So the future, is it bioprinting? Oh, I lost an image. So yes, bioprinting. Bioprinting is what basically it's based on techniques that we saw earlier. So FDM, like for the Matisse projects, inject techniques or hybrid techniques, and you use different kinds of reactive like UV light, laser, heat, or everything else. Or anything else. It's just custom. Again, it's just to find the right process that fits the needs. It's not always needed maybe to go to a bioprinter directly to print this. So it's the use of cells and polymers and cross-linkers. It's the mix of all that can make to build, that is used to build something. So that's, with that, what can you do? So basically it's syringes with extruders, okay, like FDM, and with that you can make some tissue engineering, drug screening, in vitro disease models. There were some interesting breakthroughs for the heart, the skin. It's widely used, not clinically, but yeah, the skin, the cartilage, and the cornea. So these are the kind of applications for bioprinting. And then the advantages I told them about it, just a reminder. So patient-specific precision, reduced surgery time, planification, free complexity, function integration, digital storage also, I forgot to talk about it, biointegration, and bioresorption that can be controlled. And eventually with bioprinting, now we can see the use of biological building blocks with no biocompatibility problems and no implant rejection, as you are using the same materials as you have in the body. So what do we have at Cirrus? We have a little bit of everything. We have metallic printers that can print titanium, for example, ceramic printers. So we have one which is dedicated to ceramics, but then ceramics is also possible with FDM printers and DLP printers. We have also some SLS printers, which works with powders, thermoplastic powders. And then this one, which is a little bit the Swiss knife of 3D printers, because each head there is customizable. So we can really adapt to fit the needs of the materials to do some tests on based on the requirements of the customer. So thanks for your attention. I don't know if you have any questions.
Thank you, Maxime. I propose that we move on the presentation of Jeremy, and we'll have a little time for question at the end of both of the presentation, if it's okay for you. Yep. Jeremy?
Oui.
Yeah, you can switch on your camera, and Maxime, could you stop sharing your screen?
Yes.
So Jeremy could share his.
Okay. Okay, could you see it?
Yes, it's perfect. So it's up to you.
All right, my name is Jeremy Audin, and it's a pleasure for me to introduce you with 3D print soft polymeric materials for multiple purpose. This presentation is not going to focus on medical application as expected, but will rather show you actually what we can do at the University of Mons and how we can move towards a brand new 4D printing concept. So let's first maybe talk about our motivation. As you may know, robots are typically composed of rigid components to promote high precision and controllability. But in contrast, nature does things totally differently and can do a large variety of complicated things because they are not built out of rigid component. So soft robotics, but also any other application is actually trying to seek, let's say, to mimic biological systems. And we are trying to control the shape and movement to finally replicate the function seen in humans, but also in any other type of animals. So slowly yet steadily, additive manufacturing technologies have become a major player in the fabrication of polymer device, and humans openly declare an interest into applying this 3D printing method in smart device fabrication. And we actually invest in different type of 3D printing techniques, such as the selective laser sintering. We have also filament maker and two type of fuse deposition modeling, having one printing heads or multiple printing heads. We also have different type of stereolithography techniques based on different light techniques. So either laser, LCD, or a projector, so DLP type techniques. Actually, this technique is based on specially controlled layer by layer solidification of a liquid resin by photopolymerization. And because of that, these techniques allow very high quality surface resolution, dimensional accuracy, and also it's possible to make a variety of material options. So we decide to focus on that techniques for for this presentation because it's related to soft materials. Actually, hydrogels are promising water-soluble building blocks for soft materials, and also with very strong promises for not only soft robots, but also for biomedical application, because they have elastic modulus, which is very close to the skin. They can endure very high mechanical strain. They are usually barrier compatible. They can have very high degree of transparency. They can act as an ionic conductor, which is very interesting when we want a sensing application, for instance, like artificial skin. They can also respond to diverse external stimuli, so it's very easy to integrate multiple functions such as actuation, sensing as mentioned, but also camouflage, or also even self-healing, so to really mimic what can be seen in nature. So let me move to some example of what we actually develop at the university. And here we recently demonstrate a family of ionic composite hydrogels that can be with actually excellent mechanical properties that can be rapidly 3D print at high resolution using commercial stereolithography technologies. The key of our formulation is the addition of sulfonate modified silicon nanoparticles to an ammonium-containing polyacrylamide hydrogels. And then the sulfonate group here will actually interact electrostatically with the ammonium group. So we endow the system with dynamic reversible interaction, which is of great interest to promote high performance. So as a result, the resulting 3D print ionic composite hydrogels is not only highly resilient, but will also be ionically conductive, as you can see on the video. And then to demonstrate the resilience, we 3D print an Eiffel Tower that we repeatedly stress to very large deformation. And as you can see, the system can actually restore after large damage. By using alternative electrical field here on the bear, we also were able to use the ionic transport of such ions present into the hydrogels to drive electronic device. And so we can switch on, switch off like the green light, like here, for instance. We also use our ability to photo pattern a 3D structure to print an osmotic actuator. Here, as you may probably know, here we design some structure of higher surface area to volume ratio. And if we have higher surface area to volume ratio, we will have faster swelling. So we control the diffusive swelling to design a multi-arm gripper, which is actually able to swell from a flat and open state to curve and unclose within just a couple of minutes. Inspired by nature, we also demonstrate a family of multi-responsive hydrogel-based actuators that are this time anchored with anisotropic swelling behavior to provide rapid and controllable motion. So here, the strategy is to develop such multi-responsive hydrogels is actually based on the fabrication of gradient-like structure, where we have each individual building layer with different composition, so chemical composition. We can have different cross-linking density or different surface area to volume ratio along the printing ratio direction. So we are actually able to get a control over the motion. As a model system here, we use thermoresponsive and isopropyl acrylamide as well as pH-responsive carboxyethyl acrylate, which is commonly used in conjunction with methylene bis acrylamide crosslinker to get the proposed hydrogels with near UV stereolithography technologies. So we are able to get different type of 2D print objects, which are actually soft device. Surprisingly, the proposed gradient-like hydrogels is actually shows actually continuous bidirectional bending, as you can see in that graph, in response to either temperature, pH, but also any swelling. So we further demonstrate, as you can see in the bottom, the potential of the print structure to function as a gripper for grabbing, encapsulating, and releasing any object upon thermal or pH stimulation. Let me finish here with in the frame of the 3D4Med program, Interact program. We are also focusing on designing artificial skin, which actually consists usually of an elastomer sandwich between two ionic hydrogels, which is connected to a capacitor measure, so that any touch, pressure, or stretching will cause a change in electrical signals. But we can also design artificial muscle, which actually consists of the reverse systems in which a voltage applied will cause, in this case, a change in the shapes. So we actually use our systems in touch sensing application up to now. And the ASPrint ionic hydrogels will actually generate here, as you can see on the graph, an output voltage in response to any mechanical application, any mechanical deformation. And this is related to the mechanism of the ion redistribution. So it's also interesting to see that the generate output voltage amplitude is found to be totally linear with the imposed mechanical deformation, as you can see here. All right, it's time for me to finish and to thank you for your kind attention. I just hope that I was able to show you what we can actually perform at the University of Mons. And this is only the beginning, so I really hope we will maybe find some way to collaborate together in order to move forward and develop more practical medical application. Thank you for your kind attention.
Thank you, Jeremy, and thank you again, Maxime, for your two presentations, which was complementary. I know that Samira have a little question, so it's up to
Yes,
you.
it is. Thank you. Thank you very much, Jeremy and Maxime, for very, very complimentary presentation. And you can see that you can do 3D printing and maybe now 4D printing with you, Jeremy. So it's very interesting. I would like just to ask you about something, because I don't know if you have the doctor just before, Pierre and Romain, that told us that all doctor or all nurses have to have a complete a training of 3D printing. So with your experiment, can you tell us if it's so easy to include not maybe a complete, but an efficient training to 3D printing for doctor or nurses, or if it's not so easy?
I guess it will depend on the application, on what you want to print, because there are already existing companies that do that, who provide 3D printers to hospitals to print some kind of parts, for example, orthesis. So in this field, it's possible. I guess it will also depend on the law behind, because sometimes you need also some traceability, etc. There are maybe some requirements that could not be met in an hospital. So it will depend really on what you want to print. But I think it can still be interesting, because, yeah, in an hospital you have maybe sometimes a need for specific parts that you just don't have for you. But I guess for implants, I believe for implants it would stay in companies, at least for now. Maybe it will change in the future, but at least for now, that's where I see the production.
From my point of view, I think it's something that can be done mainly at universities, where we can provide some teaching classes for medical students or nurses. So at the University of Mons, this is basically something that we are trying to develop, but this is only at the early stage right now. So it will need sometimes, but we already opened some classes just for engineers right now. But I think, and I hope, we will extend soon to any other like medical student, for instance.
Thank you, Jeremy. Thank you, Maxime.
I would also have a question, big question. We are talking about 3D printing and how we can move forward towards the 4D printing. And I was wondering whether we can have in the future, and for example, with the combination of hydrogels and polymers, a very, very complex reconstruction made, for example, with some parts of fibers for muscles, for nerves, and joining reconstruction of soft as well as hard tissues. So soft tissues and bones, for example. Do you imagine that we, in the future, and in which time, we will be able to have a very complex matrix where we can have both soft and bone tissue reconstructions, for example?
From my point of view, I think, yes, this is basically what we are trying to move. Of course, it's not that easy, because you need a perfect combination between, let's say, soft materials, but also hard materials. So rigid component as well as soft component has to be merged together. So it's not that easy to combine them all together, but I think 3D printing can do such kind of things. And with the help of some engineer, I think merging engineering with medical application will be great.
Yeah, I agree. For now, it's not ready yet, but there are people working on that and bringing it to market. You need more complex printers which are able to print more than one materials and combine them. That's the biggest challenge, yes.
And do you think the various stimuli that you can have on this matrix can help distinguish, let's say, reconstruction for soft tissues and hard tissues, or is it still very hard today to have different stimuli in the same structure?
No, I think multiple stimuli is already possible. Maybe this is not something that it was maybe you saw in my presentation, but actually the system that we made is already stimuli responsive to temperature, to pH, to humidity. So it will allow to respond to already different stimuli, let's say different environment. And this is something that we can easily tune based on the chemical composition of the soft tissue. So just by changing the composition, we can adapt the stimuli responsiveness. So yeah, that's something that we are doing. I did not mention, but we can also add some nanoparticles, which will be biocompatible somehow. And such type of nanoparticles will also add some additional functionalities also. So we have to combine, let's say, all different type of stimuli responsive materials all together in order to find, let's say, to correlate with the application and the needs.
Thank you for all the answer you provide. Unfortunately, it's time to conclude, but it was a really interesting workshop. Maybe François or Samira have a word for the end? No, it was perfect for you.
I'd just like to thank all the speakers for the very brilliant talks. And thank you all for the organization of this event as well as this hosted event.
Yes, thank you. Thank you very much.
And thank you to our colleague in the technical side. You can't see them, but there will be no workshop if they were not here. So thanks to them also. Have a nice day. Enjoy the rest of MedFit, and bye-bye.
Au revoir.
Thank you.